Today, we are going to discuss the remaining lesions in left to right shunts. The reason why we spread out left to right shunts over two classes is because from a pediatric standpoint, these are the commonest problems that you encounter, causing recurrent pneumonia, failure to thrive, coming to you repeatedly until the child's cardiac problem is dealt with. So we discussed ASD and VSD last time, and today we will go ahead with the next common congenital heart disease, namely patent ductus arteriosus. The PDA accounts for 5 to 10% of all congenital heart defects. And if you're looking at symptomatic PDA, the more serious ones, it's only about 0.5 per thousand live births. The frequency, as you know, of PDA increases with decreasing birth weight. It's a very common problem in prematurity. And you could say that if the weight is less than 1 kg, predictably there will be a ductus. And small PDAs in full-term neonates may close in the first few months of life. Large PDAs, which are present at the time of, say, 1 week, are very unlikely to close spontaneously. And the spontaneous closure after infancy is extremely uncommon, but you can't say that it doesn't happen. But it doesn't happen for large PDAs for sure. And what happens if you miss large PDAs? They march into Eisenmenger syndrome. So we have to pick up the large PDAs and treat them. PDAs can be classified from a clinical point of view according to the size of the PDA. We can conceptualize them as large, moderate, small, and tiny silent ones. The large PDAs are the ones that cause significant volume overload of the left ventricle. In echocardiographic terms, if you're looking at the left atrial size or the left ventricular size in particular, there are C-scores for the body surface area. And there are the C-score, if it exceeds +2 for the LV end diastolic dimension, you call it a dilated LV. Of course, quite often in a large PDA, visibly the LV and LA are dilated. But when you are defining an indication, you need to be sure that the LV is actually dilated. We will come to the clinical features of this separately, but I would just make the statement that in a large PDA in an infant, do not expect a prominent murmur. In a moderate PDA, there is still some degree of left heart overload, mild to moderate pulmonary arterial hypertension. Either there is no heart failure or there is mild heart failure, and you do get a continuous murmur. In a small PDA, there is minimal or no left heart volume overload. There is no pulmonary hypertension, no heart failure, and the murmur is usually continuous unless it is very small and it produces a short systolic murmur. With the advent of echo being done for very trivial indications, you do detect very tiny PDAs, which do not cause any murmur. These are called silent PDAs. If a large PDA is not associated with a continuous murmur, you do not call it a silent PDA. The silent PDAs are insignificant. They do not require any attention. So what are the clinical features of a large PDA? Features of heart failure. The baby is failing to thrive. The baby has recurrent respiratory infection. The baby has feeding difficulty. Resting respiratory rate may be faster. All these would be the features of heart failure in infancy. When you examine the baby, the pulses are striking. They are high volume. I would always say, look at the pedal pulses. If they are bounding, very likely you are dealing with a ductus in an infant. In the precordium, the heart size is increased. There is a cardiomegaly on auscultation, and there is a left ventricular apex beat. On auscultation, there is an LV third sound and apical MDM. Do not expect a continuous murmur. If you have a systolic murmur in the pulmonary area, with a child in heart failure with obvious cardiomegaly and a third sound and bounding pulses, you very likely have a large PDA. The machinery murmur and the multiple clicks that we speak about, I'm coming to that shortly, that is more likely in the older child with a small or moderate PDA. So a small or moderate PDA will also have some increase in the volume of the pulse. Apex is likely to be left ventricular, and you are likely to get the continuous murmur in the pulmonary area, which could be machinery. The, the machinery murmur is when there are multiple clicks superimposed on the continuous murmur, and these multiple clicks are eddy sounds produced from a long tortuous PDA. In a silent PDA, it's a tiny one. It is detected on echo. There is no murmur. If you are looking at the X-ray and ECG, X-ray shows a cardiomegaly and increased lung vascularity, very much like the VSD X-ray, except the descending aorta above the main pulmonary artery, you can recognize a shadow caused by the descending aorta. And ECG shows LVH with volume overload. There is good Q waves in V5, V6. Echo, which you use for confirmation, the common features are the a parasternal short axis view taken as close to the clavicle as possible in the left lateral position is called the ductal view. A suprasternal view would also show it. If you shift between suprasternal and ductal views, you can get the entire anatomy of the ductus like ampulla, length, and the diameter of the PA end, which are important measurements from our point of view for intervention. There can be different shapes, which I'll illustrate shortly. The LV and LA are enlarged and PA is dilated when the shunt is significant. There may be a mild aortic regurgitation associated with aortic root dilatation, and there may be mild mitral regurgitation because of LV dilatation. This is a ductal view. What you are seeing, look at that color flow, the red flow which is going here. And if you can see the same area on this side of the image without color, that is where the duct is. On the lower side of the image, you have the descending aorta. In the upper side, you have the pulmonary artery. The duct is superior and lateral to the left pulmonary artery. So this is what you find. This is the left pulmonary artery. Here, my marker is on the left pulmonary artery, and superior and lateral to the left pulmonary artery is the duct. They come in all sorts of shapes. This is another one. Again, the location is the same, but the shape is more like a long and tubular one, while this is a small conical one. This is a long tubular PDA, large one, technically more challenging for device closure. This is a larger PDA, but conical. So these are different shapes, as a PDA comes in all shapes. When do you close them? A large or moderate PDA with congestive heart failure and pulmonary arterial hypertension, you need to close them early by 3 months. We have already described what would be the symptoms of a large PDA. We speak of pulmonary hypertension in them. This pulmonary hypertension is driven by the flow. So when you cut off the flow, the pulmonary hypertension would resolve. You use the word hyperkinetic pulmonary arterial hypertension to refer to this type of PAH. And a moderate PDA, no congestive heart failure, 6 months to 1 year. If failure to thrive, you can close it anytime. And a smaller PDA with an audible murmur, you can close sometime between 1 and 1.5 years of time. This is mainly to highlight that the large PDAs which are causing trouble should be intervened early enough. It may be either surgical or interventional closure. And for a silent PDA, we said we don't need to close. And those presenting beyond 6 months of life with a large PDA, should be all pediatricians should refer them to a higher center for evaluation to assess operability, including deviceability. And all patients with PDA must be advised to maintain good oral and dental hygiene because we will be concerned about infective endocarditis in them. And how do we close? The larger ones, the larger babies, larger meaning weight more than 6 kg, generally it is device closure, or some other form of transcatheter closure. But if they are very large and very short, surgery may be a better option, especially if the weight is low. If you have a ductal that in the preterm baby with a symptomatic PDA, a PDA which is causing heart failure, which is causing the baby to stay on ventilator, using indomethacin, ibuprofen, or paracetamol can be used in the preterm baby. In the term baby, this is not recommended. So in the preterm baby, intervene if the baby is in heart failure. Remember, small PDAs in a preterm also may close spontaneously. So you don't necessarily need to jump in with a drug simply because you saw a small PDA. And the approved drugs are indomethacin, ibuprofen, and paracetamol. And the mode of drug administration, intravenous or oral. And at least 2 courses of drug therapy should be tried before considering surgical intervention. 50% would respond to drugs. And surgical ligation is indicated if you can't use the drugs and the baby is in trouble. So that much about PDA. Now we are going to less, not less common. They compared to ASD and VSD, they are less common, but equally important lesions, like an atrioventricular septal defect. The atrioventricular septal defects account for about 4 to 5% of all congenital heart disease, and they occur with an estimated incidence of like zero point 0.2 per thousand live births. You classify them as complete and incomplete. In the uh, clinical presentation, the decisive features are: is there a VSD? What is the size of the VSD? Is there any AV valve regurgitation? These are the prime determinants. Also, are the two ventricles of the same size, or is one ventricle terribly small? Is there any obstruction either to the right ventricular outflow or to the left ventricular outflow? And is it associated with syndromes like Down syndrome or heterotaxy? Would decide the management strategy that you are likely to adopt. We'll come to that later. Now, a complete AV septal defect means there is a large primum ASD, there's a large inlet VSD. The AV valves are common, they share a common ring. So we call it a common AV valve rather than a mitral or tricuspid AV valve. And this common AV valve may leak from any part, from the left-sided side, from the left-sided part, the equivalent of mitral, the right-sided part, the equivalent of tricuspid, or it may be actually leaking from the middle. And complete AV canal with a large VSD would be associated with large left to right shunt, pulmonary arterial hypertension, and congestive heart failure. So a complete AV, you would notice that I'm using the words AV canal defect and AV septal defect interchangeably. It's called AV canal defect because the main derivatives which are affected in this are derived from the endocardial cushion. So the other term is endocardial cushion defect. And you're using the word AV septal defect because the atrioventricular part of the ventricular septum is deficient in this condition. If you look at these cartoons, look at this image. Here are the two ventricles. The blue area represents the right ventricle. The red area represents the left ventricle. You can see a break here. That is the VSD. And if you see above that, here, this is the ASD. So there is a primum ASD. There is a inlet VSD. And the two are continuous. So even though you're calling it ASD and VSD by following the anatomic boundaries of the atrium and ventricle, what is there with the AV valve open is a common defect. And this is the actual pathology specimen demonstrating that here is the ASD part and here is the VSD part. You can see that this is a surgical photograph because there are sutures and stay sutures which are going through this to expose the defect. If that is not the case, you have a partial AV septal defect. What do we mean by that? AV valve is separate. They're divided and attached. So you can say that there is a mitral valve and there is a tricuspid valve. The most common form of a partial AV septal defect is an ostium primum ASD. There is no VSD. There is an ostium primum ASD. The two AV valves are divided and attached, but the anterior leaflet of the mitral valve always will have a cleft as the reminder that this is an AV canal defect. So a cleft anterior mitral leaflet with variable degree of mitral regurgitation is an integral part of ostium primum ASD. You can see it in this cartoon. Here is the ventricular septum. You can note that it is intact. The RV is leading on to the pulmonary artery only, but there is a large primum defect. It's inferiorly situated between the atrial septum and the AV valve. And the cartoon also highlights the fact that the mitral valve is incomplete. So the partial AV canal defect is a primum ASD. There are also some other forms. We use the words like intermediate form of AV canal defect or transitional AV canal defect. Here, there are two separate AV valves with a primum ASD and a small restrictive inlet VSD. The actually AV valves may be separate or they may share a common ring with a restrictive ventricular septal defect. You use the word intermediate or transitional AV canal defect. Less commonly, we could have an isolated cleft of the anterior mitral leaflet. Very uncommon, but when you see severe mitral regurgitation in a child, you tend to think of rheumatic heart disease. But if you have no reason to think of rheumatic heart disease, in any case, when you see mitral regurgitation, you need to look for congenital etiologies. One of the reasons is a cleft in the anterior mitral leaflet. The other form that we say, we often use the word unbalanced AV septal defect. The balance is the size of the two ventricles. If the two ventricles are both good sized, they don't need to be identical sized. But if they are both good sized, there are some ways of assessing how we say that they are good. But if they are good sized, they are balanced. But if the one ventricle is small, then you can't close that VSD and expect that ventricle to discharge its function. For example, if the left ventricle is small and in a complete AV canal defect, you're going to close the AV canal defect, the left ventricle will not be able to support systemic circulation. Likewise for RV, for pulmonary circulation. So what do we do then? We do not close the defect. We go in the single ventricle tract. We consider this then as a form of single ventricle, and that patient will have a staged Fontan operation if the criteria for Fontan are satisfied in that. That is the importance of an unbalanced AV septal defect. It should be considered as a form of single ventricle. And this is very common in heterotaxy syndromes. In right isomerism, their characteristic lesion is an unbalanced AV septal defect with DORV and pulmonary stenosis or atresia. In left isomerism also it can happen. This is in the last 2 years or so, what my unit had seen, just to highlight the different forms of AV septal defect. Overwhelmingly, complete AV septal defect is what we would see. And the complete AV septal defect, I'm coming to this point separately also, is likely to be with Down syndrome. So this is complete AV septal defect, the bigger part of the pie. And the smaller part, which is only one case, is to remind that complete AV canal defect can also be associated with other serious problems like an arch problem. So that one case was AV canal defect with an intermediate aortic arch. There were two cases of primum ASD and one unbalanced AV septal defect in a 22-year-old man who had a Fontan completion. So they come in all forms and varieties. And the complete AV septal defects underwent surgery at a median age of 3 months, whereas that interrupted aortic arch will compel you to repair the AV septal defect in the newborn period itself. So when it is an unbalanced canal, You take them through the single ventricle tract. And in this particular case of unbalanced AV septal defect, this was a neglected patient who underwent completion at 22 years of age. We need to make a comment on Down syndrome and AV septal defect. Down syndrome is present in half the cases of AV septal defect. If you're taking AV septal defect and backward, half of them will have Down syndrome. And 40 to 45% of children with Down syndrome. Now we are looking at children with Down syndrome, not children with AV septal defect. If you take all children with Down syndrome, 40 to 45% of them will have congenital heart disease. Now of these, almost half is AV septal defect. Down syndrome could also have a regular perimembranous VSD or a secondum ASD or a regular tetralogy of Fallot. All these could be present. But half the cases of Down syndrome will have AV septal defect itself. And the majority of AV septal defects in Down syndrome tend to be complete. The problem with AV septal defect in Down syndrome is Down syndrome have this greater propensity for pulmonary vascular disease. Therefore, the Down syndrome kid with large AV septal defect may not have much symptoms. You need to pick them up by routine screening of Down syndrome for congenital heart disease, one, and recognize that please, I'm having a lot of feedback from the listeners. Please do not talk.
Government.
Hello. Yeah. Please be sure that you are not talking into the mic. We were discussing Down syndrome and saying that nearly half of them will have congenital heart disease, and half of this congenital heart disease AV septal defect. And if there is a large AV septal defect in a Down syndrome child, pulmonary vascular disease tends to develop at a rapid pace, and therefore it is mandatory that you should try to operate by 3 months of age, definitely before 6 months of age. And if there is a left AV valve regurgitation, if there is severe left AV valve regurgitation, there is some degree of residual AV valve regurgitation is likely, and this might progress in future. In other words, one of the common problems in operated AV canal is that they may have residual AV valve regurgitation, which may progress and you may need to reoperate for that later in life. So how do you work up a AV canal defect? In clinical examination, look specifically for Down syndrome, and you should also look for features of atrial septal defect on examination. If what you are getting is a wide and fixed split to the second sound, that suggests that AV septal defect is predominantly a primum ASD, and association of mitral regurgitation is common. If you are seeing a complete AV canal defect with a large ventricular component, the clinical features will be of VSD, cardiomegaly. Disproportionate pulmonary arterial hypertension is likely. And the chest X-ray would show cardiomegaly depending on the size of the VSD and the degree of AV valve regurgitation. And increased pulmonary vascular markings and prominent pulmonary artery conus, as you would expect in a patient with a large VSD. In this context, I should also mention that today we do fetal echoes very commonly. So in the antenatal period, complete AV canal defect is very easily picked up. And if you are picking up AV canal defect antenatally, there is a strong possibility that there is associated Down syndrome. So looking for Down syndrome features, like there are various antenatal markers for Down syndrome, including the increased nuchal thickness. We look for that and manage accordingly. This is an ECG of a patient with a complete AV canal defect. If you can see the axis, see the lead 1 is positive, lead 2 is negative, and AVR is positive. This shows a left axis deviation with Look at V1. V1 is an RSR. So you have a complete RBBB. You have a left axis deviation. Normal regular VSD will not have a left axis deviation. But left axis deviation is a feature of AV canal defect even if there is no VSD. Even ostium primum ASD will have a left axis deviation. Right bundle branch block is to be expected. Very commonly, the PR interval is prolonged, suggesting that there is some degree of AV block. Echo is, of course, the key tool, and this is for the diagnosis and assessment of size of the ASD and VSD and size of the ventricles, balanced or unbalanced. You can estimate the pulmonary artery pressures. You can assess the presence and severity of AV valve regurgitation, and you can look for associated lesions like tetralogy of Fallot, LV outflow obstruction, arch interruption. These things can be looked for. If you see this image, this is the typical image of complete AV canal defect. Now, what is seen here? This is the right atrium, left atrium, right ventricle, left ventricle. Now, my marker is on the ventricular component of the AV septal defect. Remember, we said even though we say there's an ASD and there is a VSD and all, when the valve is open, what you see is a single continuous defect. And the part above the AV valve you call a primum ASD, the part below the AV valve you call it a inlet VSD. In this particular case, there is a small secondum ASD in addition here. And you can see that both the ventricles are good size, so this is a complete balanced AV septal defect. When do you operate on them? In any AV septal defect with uncontrolled heart failure, complete surgical repair is needed as soon as possible. And even if the heart failure is controlled, you should try to do complete surgical repair by 3 months of age. In complete AV canal defect, the golden period for surgery is around 3 months of age. Ordinarily, by the time heart failure would have just started, the child would have gained some weight from the pre-op period, from the neonatal period, and the child hasn't become very sick due to recurrent infections. So it is ideal to operate by 3 months of age. If you remember the pie chart that I showed, the 10 of them were complete AV canal, and all of them were operated at 3 to 4 months, and some at 2 to 3 months. A partial or intermediate AVSD which has no symptoms, which means you're dealing with an ostium primum ASD, you can repair at 2 to 3 years of age. Many units would operate on them even earlier. And when there is associated AV valve regurgitation which is significant, heart failure tends to occur, and even in a partial or intermediate form, it will push you into operating early. So complete AV septal defect around 3 months, and the ostium primum ASD without any problem beyond 1 year or around 2 years with mitral regurgitation. Depending on the severity and the trouble caused by the mitral regurgitation, earlier surgery would be needed. The remaining lesion is an aortopulmonary window. What is an aortopulmonary window? You can think of a VSD as something which is occurring within the ventricle. But if there is a defect between the two great vessels, aorta and the pulmonary artery, there is a hole separating, connecting the aorta and the pulmonary artery. You call it an aortopulmonary window. This defect is usually large. It is an uncommon lesion, and quite often it is associated with other anomalies. Which one common anomaly is interrupted aortic arch. The right pulmonary artery may arise from the aorta. There may be coarctation of aorta, and abnormal coronary artery origin from the main pulmonary artery. Either the right coronary artery or the left coronary artery may arise from the main pulmonary artery like Alcapa. You may get AP window with tetralogy fellow also. So AP window is a major problem, mercifully uncommon, but it does occur, and the defect is large and the patient tends to march into pulmonary hypertension very often. The clinical features will depend on how big is the AP window. Generally, they are big. Of course, the relative systemic and pulmonary vascular resistance, whether there is any associated lesion, if there is an interrupted aortic arch when the duct closes, it's a duct-dependent systemic circulation, baby will crash in the newborn period. Otherwise, large AP window is associated with early development of advanced pulmonary vascular disease. When we go into underprivileged regions of this country or the third world in general, one of the things that we find in older children with Eisenmenger syndrome is a previously undetected AP window. It tends to get ignored and the patient presents for the first time with Eisenmenger syndrome. There are different types of AP window depending on where it is located in relation to the pulmonary valve. If it is located very close to the pulmonary valve, just above the sinus of valsalva, it's called a type 1 or a proximal defect. The other end, before the pulmonary artery bifurcation, it's not close to the pulmonary valve, but it's close to the pulmonary artery bifurcation. You call it a type 2 or a distal defect. The type 3 or a total defect, you can't say where it is. It is there right from the pulmonary sinus to the bifurcation. So that's a total defect. And you could call it an intermediate defect because it is right in the middle with a nice superior and inferior rim. But the commonest one is a large proximal defect. This image represents an AP window. Look, see here, this is aorta, this is pulmonary artery, this is the pulmonary valve. See here, there's a large defect connecting the aorta to the pulmonary artery. That is a large AP window. When do you operate on them? Treat them like a VSD. The surgical repair should be as soon as possible if there is uncontrolled heart failure. If there is no symptoms or if there is controlled heart failure and the VSD is large or even moderate, the AP window is large or moderate in size, you should do elective repair by 3 months of age. And in patients with associated anomalies, generally you'd like to do it as a single stage repair. For instance, if there is an AP window with an interrupted aortic arch, you'll have to repair everything in the newborn period together. The tragedy is you will find patients presenting beyond 6 months with severe PAH. They will have to be critically evaluated for operability. And we would also recommend that all patients with AP window maintain good oral and dental hygiene because the risk of endocarditis is definitely there. I should invite your attention to this paper which is recently published. We have an Indian working group on congenital heart disease, which is guided from the All India Institute of Medical Sciences. So we have recently come out with the Indian guidelines for indication and timing of intervention in congenital heart disease. I would like all of you to be familiar with this. Published by the Working Group on Congenital Heart Disease in Annals of Pediatric Cardiology. It will also very shortly appear in the Indian Pediatrics. This is the reference for Annals of Pediatric Cardiology. Annals of Pediatric Cardiology, access is free, so you can get this online. It's very important that you be familiar with such a document as your reference document on timing of intervention. I'll conclude here. I've deliberately made this a short class because in left to right shunts, there could be a lot of questions. And we have discussed last time for ASD, VSD, and this time for the other lesions. So I would expect multiple questions from you, and I would be happy to answer them. Thank you. Any questions? I'll be disappointed if you have no questions with regard to ASD, VSD, PDA, and AP window and AV canal. You can ask the questions by chatting. Any questions? Well, if you have no questions, we are going to wind up.
Any questions?
Mrta, we have a deafening silence. So,
Any questions? Any doubts or any questions?
well, then let us conclude.
Okay, sir. Thank you. Thank you for your wonderful presentation.
Thanks, Mrta. Then signing out.